Chronic total occlusion, or CTOs, are among the most technically challenging procedures in interventional cardiology. I will show you what cath lab nurses must know to feel more confident when assisting these cases. There is not enough research on the nurse's perspective on CTOs, and when I asked some cath lab nurses about the procedure, most of them said the same thing, that they don't get enough training. Most of the books and resources available are for interventional cardiologists, and nurses are left trying to figure out for themselves. The procedure is fast-paced, there are many guide wires and not enough time to label them. And because of this, some nurses feel overwhelmed. So let's make CTO clear and empower health professionals with the information they need. During CTOs, cath lab nurses must be familiar with different wires, devices, and techniques. This requires knowledge and skills to use specific material and manage complications. CTO is the complete blockage of a coronary artery for over 3 months. Thrombolysis in myocardial infarction flow rates are used to describe blood flow in coronary arteries, and the scale goes from 0 to 3. 3 means normal flow, but 0 suggests the most severe form of occlusion. If the myocardium is viable, the possible benefit for the patient is basically to increase survival. And when the procedure is successful, it can improve symptoms of angina, ventricular function, and quality of life. CTOs often require different approaches, and they tend to be longer than other percutaneous coronary interventions. Cath lab nurses need to support the patients, assist the operators, administer medication, and prepare the material that goes on the trolley. A well-informed nurse can anticipate needs, streamline a workflow, and contribute to a safer and more efficient procedure. The setup for CTO cases is more complex than standard PCIs. Understanding the tools and their uses improve readiness and reduces procedure time. CTO interventions require specific guide wires, microcatheters, contrast use, and dual arterial access. A nurse familiar with CTO can organize the trolley more efficiently, manage treatment, and assist proactively during the case. CTO cases involve higher contrast volume and radiation exposure. To ensure patient safety, nurses need to monitor contrast volumes, hydration, and radiation times closely. Knowing CTO-specific terms and steps, such as knuckling a wire or externalization, enhances communication with the operator and the team. And always listen to the patient's concerns, reassure them, and advocate for pain relief if necessary. Patients might ask why CTO was chosen, how it's different from regular angioplasty, and what recovery it will involve. Informed nurses can educate patients, help them manage expectations, support their recovery, and improve their satisfaction. The more complex the procedure, the more risks involved, and consequently, more competences are required. CTO procedures meet many challenges, and one of the most important things for a scrub nurse handling different guide wires is to recognize which is which. The operator selects the wires based on the morphology of the lesion and the response to initial attempts. To prepare the material and assist the operators more efficiently, cath lab nurses must be attentive to the approach adopted, the wires required, and the possible complications. Guide wires consist of 4 components: the core, the tip, the coating, and the cover. The inner part of the guide wire is the core. The stiffest part of the guide wire gives stability from the proximal end to the distal tip. The distal part of the wire, or tip, is essential for lesion crossing and precise steering. These are the main characteristics of the guide wires. Operators escalate from soft to stiff, but they also de-escalate when they need to cross the blocked vessel safely and reduce the risk of injury and trauma to the vessel. It's important to combine wires with supportive devices. These are some types of CTO wires. All guide wires have a specific surface design, such as stainless steel coils, plastic covers, and hydrophilic or hydrophobic coatings. The manipulation of a wire is a two-step process, shaping the tip and steering the wire through the vessel. Although guide wires are chosen according to the anatomy of the vessel and type of lesion, in real life it depends a lot on the operator's experience and preference. So rather than talking about all the guide wires available, it is more reasonable to understand their characteristics. Choosing the right wire is fundamental. Operators start with workhorse wires, which are standard for most initial crossings because they balance pushability with tip flexibility. The BMW is widely used because the tip is soft, shapeable, and good for torque control, which makes it safe and predictable. Another wire is the cyan blue that has a hydrophilic coating, which reduces friction and improves trackability through tortoise anatomy. These two wires lay the ground for understanding escalation to stiffer and more specialized wires. Operators start with soft wires to avoid creating false passages. When soft wires fail, operators escalate to intermediate wires. Check out the difference in the tip load. Stiff wires can dissect or perforate if not used carefully, and they are often paired with microcatheters for support. Polymer jacked wires are good for tracking, but they might not give the best feedback. So operators need to balance use with their skills to control the wire. Hydrophilic wires pass easily through tortuous vessels, but they need careful control, while non-hydrophilic wires offer better feedback and are ideal for precise controlled penetration. Supportive equipment helps navigate tough, blocked vessels by improving stability, enhancing control, and allowing a more precise delivery through a challenging anatomy. There are multiple factors that contribute to a successful coronary intervention. One is choosing the right wires, and of course, it's also critical to choose the right technique. It is common for operators to start with an antegrade approach. Antegrade follows the natural blood flow, and the wire is advanced from the normal vessel toward the blockage. In retrograde, the wire is advanced backward through collateral vessels to cross the blockage from the opposite side of blood flow. Both antegrade or retrograde involve a stepwise use of guide wires with increasing stiffness and penetration power. However, during lesion crossing, sometimes it's possible to de-escalate the guide wire's penetration to navigate more safely within the occlusion. And if necessary, re-escalation can also be performed. These different wire-based techniques have led the CTO Academy Research Consortium to recommend that we stop calling it wire escalation. Instead, we should call it antegrade wiring or retrograde wiring, which implies the possibility of both escalation and de-escalation. Parallel wire or re-entry techniques involve intentionally creating a pathway around the blockage and then re-entering the true vessel beyond the occlusion. This is done to bypass hard blockages when direct crossing is not possible. Some things can go wrong, especially with hydrophilic or stiff wires. The wire can end up entering a subintimal space. To fix it, operators use re-entry devices, such as the Stingray balloon, or they can also consider parallel wire technique. If antegrade fails, they switch to retrograde. When all techniques fail and operators cannot cross the occlusion, they might switch approach and consider IVUS for cap identification. They can also use CART or reverse CART. Scrub nurses need to be prepared to assist any shift in strategy. Likewise, the circulating nurse must document the details of the procedure, manage medication, and inform patient and the team. Operators always adapt their strategy to the lesion's characteristics. It's not one size fits all. The same is true to the choice of wires. Hospitals might stock different wires to the ones I showed, and it is also down to the operator's individual preferences. A structured protocol ensures that all necessary equipment is ready, preventing delays or mistakes, especially in wire selection. Remember that CTO carry risks like vessel perforation or tamponade, so being systematic helps nurses respond instantly with emergency kits, covered stents, or reversal drugs if something goes wrong. A good setup minimizes delays and enhances the flow during the procedure. Some key elements for the preparation of a CTO trolley include a dual manifold system with stickers, usually red and blue, to avoid confusion. There are two pressure lines, one to monitor the aortic root and another from the guiding catheter. A dual access increases the chance of a successful crossing of the CTO, while the 7 French guides optimize the internal diameter for all the equipment that is required. Wires may be reused, so they must be carefully stored in labeled casings to maintain sterility. In general, operators usually take images using retrograde injection first, followed by antegrade. If operators used a single injection, it would just increase the likelihood of overestimation. To avoid that, they use a dual injection of contrast to quantify the length of the occlusion. And CTOs can last more than 2 hours because of the complexity of the lesion. So longer fluoroscopy times mean more injections of contrast medium. Now, contrast causes renal vasoconstriction and reduced perfusion, which can lead to ischemia, tubular toxicity, and calcium overload. The guiding principle of radiation safety is ALARA, which stands for as low as reasonably achievable. It is important to set up contrast strategies with a limit lower than 3 times the estimated glomerular filtration. Nurses must be proactive and keep the team informed about the amount of contrast used at every 50 or 100 milliliters to prevent complications like contrast-induced nephropathy and radiation burns. And renal function must be monitored with IV fluids administered pre- and post-procedure. CTO interventions often run longer than standard PCI, increasing the risk of thrombus formation. That's why heparin dosing is critical. A bolus of 70 to 100 units per kilogram is given immediately after arterial access. Throughout the procedure, the activated clotting time, or ACT, is monitored at regular intervals of 20 to 30 minutes, aiming for a value between 250 and 350 seconds. This reduces the risk of thrombotic complications while adjusting individual bleeding risks. The procedure carries risks such as abrupt vessel closure, perforation, and tamponade. Cardiac tamponade is when fluid compresses the heart, stopping it from filling. It may be sudden or slow, and this can be confirmed with an echo. In case of tamponade, doctors do a pericardiocentesis, and anticoagulation is reversed with protamine. Nursing support is essential to anticipate complications, assist decision-making, and maintain patient safety. In case of a false lumen or subintimal tracking, both the scrub and circulating nurse must watch the ECG closely, keep an eye on the hemodynamic, and flag any significant changes. If there is a coronary perforation, have a pericardiocentesis kit ready. Monitor any signs of tamponade and make sure protamine is on hand. For dissection, stay alert to changes in the pressure waveforms and keep an eye on the contrast patterns. Also be prepared for intravascular imaging because the team might use IVUS or OCT to assess the extent of dissection. Where there is a risk of injury, watch the wire tension and keep an eye on the navigation through the collaterals. The wire or the microcatheter can also get stuck in calcified segments. This is called entrapment. Make sure retrieval tools are available. Doctors might use rotablation, for example. If the device cannot be retrieved, the operators may have to consider surgical consultation. Track how much contrast is being used, monitor IV fluids, and speak up for breaks or adjustments if needed. If the crossing fails, assist in the shift to a new strategy and document everything. A systematic approach includes standard post-procedure protocols for observation, sheath removal, and monitoring complications. Vital signs should be checked regularly and vascular observations done thoroughly, especially if large sheaths or dual access were used. Check if pedal pulses are present. Check puncture site for signs of bleeding. Ask your patient if they feel any chest pain. Administer prescribed medication accordingly, always checking for allergies and intolerance. Patients may be sore or drowsy due to sedation, so reassure them. Monitor input and output. Encourage hydration to protect the kidneys, and make sure your patient is aware to not strain the access site when mobilizing. Let them know that the team used complex techniques to open a long-term blockage and that it may take time to feel the full benefit. Following this structure of knowing the wires, understanding the approaches, and staying alert help the team keep things smooth and safe for the patient. In this presentation, I talked about CTO interventions and how cath lab nurses can make a real difference by anticipating needs, monitoring complications, and supporting the team for the best outcomes. Special thanks to Dr. Thomas Kyer, the cath lab nurses at Royal Papworth Hospital, and the teams at MedicStat and VP Med Group for their valuable input and contributions. For a copy of the Pocket Guide to Terminology, Do You Speak CTO? By the VP Med Group, please scan the QR code below. If you have any comments or questions, please get in touch, and thank you for watching.